After infiltration anesthesia, we start with a mid-crestal incision with a blade number 15. Then we continue with the intracellular incision, distal and then mesial of the edentulous space. We continue the intracellular incision with the back of the blade to protect the sensitive buccal tissues. We can then complete the intracellular incision with a periotome. The periotome is a non-cutting instrument and can gently and effectively detach the gingival tissue from around the teeth and allow first contact with the underlying bone. Once the bone is initially exposed, we can begin the flap elevation with the periosteal elevators. A thin and sharp elevator might be needed for the thinner and more fragile buccal flap, while a wider elevator will be used often in the palatal side. At this stage, a release incision will be required in order to have complete access to the bone defect. The design of the release incision follows the shape of a golf club in order to allow best conditions for the flap closure and healing. Having achieved full access to the bone defect, a round burr is used to locate the implant position, and then we can start our osteotomy with the first drill, which in this case is 2.2 millimeters in diameter. After the first drill, we can control the depth and angle of our osteotomy with the respective 2.2 millimeter gouges. The drilling sequence continues with a 2.8. After each drill, the gauge will help us control the depth and angle of our osteotomy and match it to the planned prosthetic position. Finally, cutting the threads into the bone for an optimal seating of the implant in the osteotomy, which in this case is being placed with a handpiece at 30 rounds per minute. A healing abutment is connected on top of the implant, as we will prepare the implant for transmucosal healing. A resorbable membrane is stabilized around the implant. The membrane is trimmed in order to completely cover the bone defect and is stabilized around the healing abutment. After the membrane is stabilized, a bovine xenograft is gently placed in the bone defect. Once the desired morphology of the bone is achieved, the membrane is flipped back under the buccal flap in order to completely isolate the regenerated area. The release incision is closed with one suspension suture at the tip of the flap and two single interrupted sutures in a more apical position.